did your colleagues like the transition to digital pathology?
Well, it varies according to the
Yeah.
individual. Somebody still stick to the microscope. I know we need some time to everybody get used to digital. Implementing it, well, I didn't feel much difficulty to get the machine and start looking at digital images. And as far as the reporting is the same format, we have to look very carefully at the digital image. We have to be very careful that we really watching the exact same changes in digital image. We can feel more secure. I mean, AI doesn't replace pathologists, but we feel more confident, secure.
I think you guys were super motivated if you still have to do glass, but
Yeah,
also
but
did digital pathology.
Yeah, right, yeah.
So that
Yeah.
is, I think, an important step when you want to drive adoption of something, and also gather data to show the regulators that, hey, at some point we can drop the glass.
I think in the future of pathology is more patient-oriented.
This episode is one of our special MUSE Cup episodes that were all sponsored by MUSE Microscopy. So let's dive into it. Welcome, my digital pathology trailblazers. I have another guest for the special edition podcast at ASCAP. This is Dr. Robert Osamura from Japan. Welcome, Bob, to the podcast. How are you today?
Okay, thank you. My name is Bob Osamura, and I'm a practicing pathologist at the community hospital now. And I've worked for IAP, International Academy of Pathology, and International Academy of Cytology, as well as Digital Pathology Association, DPA. And I'm really interested in endocrine pathology, breast pathology, and digital pathology. And particularly recent application for the AI, artificial intelligence, is very attractive, and we should think of how we use efficiently in our future practice.
So currently, what's the place that you practice right now?
I'm
Which
at
hospital?
Kokan Hospital, Nippon Kokan Hospital,
Okay.
near Tokyo, in Kawasaki. Yeah.
How big is your hospital?
About 300 beds. Yeah.
And is it a big one in Japan, or like compared to others, is it a big institution?
Well, it's a rather small size hospital, and we do practice in pathology in various tissues, different kinds of tissue, and we apply digital pathology in the small biopsies, and we read them every day. Yeah.
So you use digital pathology every day for your normal pathology job, right? For biopsies.
We are the colleagues read double check with microscope.
They do. So you have a double workflow.
Yeah.
When did you start doing that?
About 4 years ago. Yeah.
And what is your workflow with digital pathology? Like, what scanners do you have? Just tell me basically how you implemented digital pathology in your institution.
Just regular work. Routine diagnosis. Small biopsy first. Takes a short period to scan the image. If we work on a larger specimen, it takes longer time. So we do only small biopsies.
Okay.
Yeah.
And how many scanners do you have?
Only one.
Oh, one.
Yeah, Hamamatsu S201 210.
Japanese
Japanese
scanner in Japan.
It's a very good. Yeah. We selectively scan cytology, but not the routine work. Yeah.
So why did you decide to implement digital pathology in your institution? What was the driving force? Why did you decide that you need to have that technology in addition to glass slides?
Well, first I was interested in the digital image, how practically useful. So we started testing that, and we realized that that's very good easy to scan, lower power, and easy to go higher power, and I think it's very efficient, and still very enjoying looking at the image. And also, you can send the image in the hospital, like a conference, and also at outpatient clinic. They can share the image, which cannot be done with a microscope.
Yes,
And
or
so-
it takes very, very long time.
Yeah. Also consultation. Yeah, if a difficult case, we can send out. Well, of course, we have to be careful about
The-
privacies and also all that, but protecting those privacies of patients, it's very convenient.
And so you guys have in Japan in general a unique use case because you are a country of islands. So this connectivity that digital pathology provides gives you an advantage that is like more of an advantage than in a country that is basically connected by land and have land-based transportation.
That's true. So by digital image, you can easily cross the ocean. So we enjoy that. And also going back to the hospital inside, the clinicians can appreciate the digital image.
Oh, so you do have the pathologists collaborate with the clinician and look at the images.
Clinical chart is digital. I mean, on the screen. I mean, in the computer. So the clinicians can click on the image and they can confirm what we say, diagnosis. Yeah.
Oh, amazing. You mentioned that your pathologists do digital pathology of the biopsies and glass in parallel
Yeah,
for the
that's
same
probably,
tissues or for different tissues? Like
well,
you do.
same tissue. Yeah.
So you have both a digital image and a glass slide
Yeah,
for them to review.
there's a regulation by the government, still. Well, right now it's getting more practically the use of digital image, but up until recently, we have to compare both digital and microscopic images.
While you're evaluating one case, like in the same workflow.
Yeah, but there was a thought, we have to confirm by looking at the microscope.
Ah,
Yeah.
okay.
But now it's changing now.
Uh-huh.
So only a digital image can be.
I think so because obviously this is different than in the US. Now you can do primary diagnosis without the reconfirmation on glass. I think you guys were super motivated if you still had to do glass, but also did digital pathology.
Yeah, right, yeah.
So that is, I think, an important step when you want to drive adoption of something and also gather data to show the regulators that, hey, at some point we can drop the glass. It's good enough.
That's right, yeah.
And let us just
I think
do
it's about time we can look at only digital images. Yeah.
What's the process in Japan? Like you would have to submit some studies or like how do you have the conversation with your regulators?
Yeah, there's like FDA, we have PMDA, the government, which regulates those all the rules for the diagnostic regulation and also reimbursement. So right now, if a hospital without pathologist, they can scan the image and send the image to the larger hospital with pathologist. So make a diagnosis, and then two hospitals can share the reimbursement.
Oh, okay.
Yeah. So that's probably a big advance, future step for the digital pathology in Japan.
Was it?
But still a long way to go. Yeah.
I mean, in the US, it's still a long way to go.
yeah,
I think across the globe, and we're gonna talk about it in a second because we're at the MUSE microscopy booth, and they are the sponsor of this whole series of podcasts, and they're like the next innovation. But before we go there, I want to ask you, when you were implementing digital pathology, when you started your revolution at your institution, what were the challenges? Like, what was difficult, or did everybody like came on board immediately and liked it, or what pushback did you get? How did you go about implementing it?
Implementing it, well, I didn't feel much difficulty to get the machine and start looking digital. images, and as far as the reporting is the same format. Yeah,
Okay.
Yeah. So then we have to look very carefully at the digital image. First, we have to be very careful about. We really watching the exact same changes in digital image. Sometimes very small organisms, very difficult to see, and we have to confirm by the microscope sometimes. But now we realize some of them really, when we get used to it, we can look at it. But still, I have a microscope always. So anytime I have a little question, I can easily go to the microscope. I think that's very important.
And
Throw the microscope away, somebody said, but
no. And when I was hearing at presentations or from other podcast guests about their implementation journey at their institutions, there was often a period for the pathologists. Even now in the US, you don't need the glass. The pathologist can always ask for the glass if they need it. And also when they were starting the whole process, they would let the pathologist always have the glass if they wanted to. And the time frame when the last pathologist would say, okay, I don't need the glass anymore, would be 6 months.
What do you mean with that?
So you would have a period of 6 months where everybody gets the image and the glass. And the pathologist says, they themselves would say when they are confident and drop out the glass. And the latest adopters would last 6 months with both.
Probably, yeah.
And then they said, okay, digital. But always when there is something that they want to confirm, something that they need to check, they can ask for the glass.
Glass, yeah. That's exactly what I'm saying. We can't throw the microscope away.
I mean, the microscope...
I don't know, in 10 years,
Maybe when we implement the MUSE. The microscope is also... So the whole slide scanner is actually a microscope. It has objectives, it has all the components of a microscope, but creates a digital image instead of the analog that we see through the microscope. How did your colleagues like the transition to digital pathology? Did you have
it varies according to the individual. Somebody still stick to the microscope. Yeah, that's okay. I know we need some time to everybody's get used to digital, but eventually, I think we use digital images.
So now let's talk about the MUSE technology, which is the direct to digital imaging from tissue sections. And where do you think that would help you in your current...
In MUSE?
Yes, if you would have the MUSE system, if this was all ready to go, what would be your application? Where would you use it first? Where would you use it second? What are the advantages that you see for your particular use case in your country, in your hospital, how you work?
Let me think. If I have that machine, probably I use it for the first. I apply for the intraoperative diagnosis, and if the surgeons are waiting in the operation room, and we can just put the tissue, fragment tissue, and cut the plane, get the digital image, and I heard it is a virtual color can be used.
Yeah.
So I hope it takes much shorter. So then we can reply to the surgeon very quickly, and then the surgeons can go to the next step. So I think the first application I can think of is intraoperative rapid diagnosis. But then if we can use fixed tissue fragment, then we can use for the permanent diagnosis. So probably we can think of two ways: rapid diagnosis and also permanent diagnosis. Yeah, but permanent. Then right now we have a section stain. That's a permanent. We can save it permanent. But if it's a chunk of tissue, Even if fixed, we can't keep it forever.
That's
So
true. You
then,
would,
then
you would
uh,
need to.
we have to think about it. But anyway, we can make a permanent image to keep as a digital level. I think it's good, and so I know recently there's virtual color, and even it's immunohistochemistry can be virtual color. So everything, once you have a plane, cut the plane of the tissue, we can start thinking about H&E, and based on H&E, we can make a virtual color, the various things. Everything is a virtual. That's probably one way we can think of. I'm not sure how much.
I mean, we're hypothesizing right
Yeah,
now,
yeah, right,
but
yeah.
that's the question I have.
Yeah,
I
yeah.
want to see like where do different key opinion leaders from different corners of the world see this being applied, and frozen sections intraoperative is something that comes back over and over.
Yeah.
So I wanted to ask you. Go ahead.
Excuse me. The frozen section is, as you know, it's histology, morphology is less satisfactory. I mean,
Yes,
yeah.
everybody
Compared
says
to
that they
the,
don't like frozen sections
yeah.
compared to
So
H&E.
I think looking at the MUSE technology, I think it look better than the frozen section.
Definitely, I think so too. And what I wanted to ask you about is about what you already mentioned, that some hospitals don't have pathologists, and then they can collaborate with hospitals that have pathologists. Like how many, like outside of big cities in Japan, how many remote areas do you have? Is there a lot of hospitals in the remote areas
Not
or
yet.
care places? Is this a problem there,
Well,
or a reality rather than a problem?
theoretically, it's a very good system, you know. But reality
Because they're
is
famous for good
this hospital
systems in
without
Japan.
pathologists have to have the scanner
Yes.
to the scan image and send it to the pathologist.
So they
So
also.
that's it's a very expensive scanner. So if those MUSE scanner is less expensive,
Then it's a solution, right?
Yeah, and also technologists can manage to cut the plane and send an image. Then probably it become very popular.
I can imagine that as well. Also, we say that if they can send a slide to the pathologist, that means they need to have the histology laboratory, right? Or can they send tissues?
Right.
But if they send tissues, then they probably cannot share the reimbursement, right? Because then everything goes to the hospital where you send this.
Yeah.
Interesting.
I mean, not secure.
If you have it and if you can confirm it.
Yeah,
And I think many pathologists, especially the more experienced one, the older generation, they want that backup. This is what they trained on. This is what we all trained on. I'm a veterinary pathologist by training.
Oh, you?
Yes, now working in drug development. But this is like, we trained on glass, and many feel a lot more secure doing work on glass than on digital. Even though the image is generated in the same way, it's still light microscopy.
Yeah. And digital image is good enough to make just ordinary changes of morphology. But some detailed, very minute changes or organisms, then I need some confirmation.
Yeah, that's totally justified.
Yeah.
And
Then if you use AI, then if AI works much better, then we can just run the AI first, then let them pick up some of those small changes, and then we can feel more secure. Yeah. I mean, AI doesn't replace pathologists, but we feel more confident, secure.
you have like a tool that already points out things, kind of pre-screens things for you,
That's right,
and
yeah.
can confirm, or if you disagree, you can just disregard this and do your own analysis.
Right.
One more thing before we wrap up that I wanted to ask you. Do you know what's the percentage, how many hospitals in Japan are doing digital pathology? Is it a lot? Is it not so many?
Very good and difficult question to answer.
I know
I would
that in
say-
Asia it varies per country a
varies, and still, because of the very limitation, like cost of the scanners and several other things, I would say still very limited hospitals use fully digital system. They might have a scanner, but
Okay.
how practically they use, I'm not sure, but it's very limited still. So how we can go further? Probably we should be more familiar with the system, and also scanners should be more popular and can get in the lab. So
Maybe-
still, it's very expensive. Like right now in Japan, government approves Hamamatsu, Philips, and Leica.
Okay.
So they're good
These are
price.
the main- yeah. Yes, and obviously, MUSE is a new device,
Yeah.
so that's going to be another regulatory pathway, different in
Yeah.
different countries. I'm excited about this.
Yeah.
Let's see.
But I'm looking forward to be using the digital images as a routine work, and also if it's combined with AI, maybe we can predict some molecular changes or more give us applicable information about the treatment.
Uh-huh.
Yeah.
Yes.
So I think in the future of pathologists is more patient-oriented and more clinical information.
That is also a theme that comes back again because it's a little bit pathologists are looking forward to having systems and devices and software make them more efficient.
Yeah.
But not so that they can do even more job, but rather so that they can be more involved in patient care,
That's the point.
interacting with
Yeah.
clinicians, in being part of the patient care team,
Yeah.
and not just this specialty that delivers a report and somebody else takes it.
That's right. Yeah.
So I think also for our profession, this is
that's exactly what I'm thinking, and also many people are thinking, pathologists in the future. Yeah. Otherwise, no reason to be digitized or
what's the
AI.
point?
Yeah.
I think the same.
Yeah.
Thank you so much for joining me. What I wanted to ask you yet before we go is where can the listeners learn more about your work? You mentioned you're active in Digital Pathology Association as well.
I'm a member of Education Committee, and
Okay.
I joined the committee meeting, and I'm available. But
Okay.
yeah,
So, if anybody wants to, yes,
give me my
please,
card.
I would love to get your card.
Yeah.
Thank
I'm
you very
working
much.
at hospital, and my email address.
Okay, so there
Yeah.
is the website www.iapjapan.org.
This is the
Oh, that's the
IAP,
International Academy of Pathology, Japan. Okay, so definitely we can check this website.
This is the next year we host International Congress.
Oh,
So that's a good,
congratulations in Fukuoka.
Yeah, Fukuoka. That's a southern part, big city.
Okay, so if anybody wants to visit Japan in Fukuoka, 8th to 13th of October. Thank you so much.
You're welcome to come. Yeah.
Yes, now we have to go to Japan.
Yeah. Right.